Hello and welcome to Two Peds in a Pod, the medical education podcast from the Children's Emergency at Derby. My name's Ian Lewins, one of the consultants, and I'm really pleased to be joined today by two of my neonatal colleagues. So I've got Shaun Edwards, who's a neonatal nurse educator here in Derby, and I'm very pleased to be joined by Kellie Fraser, who's again a neonatal nurse educator based at Northampton. Welcome.
Hi.
And thank you very much for coming across to Derby, where the sun always shines. So today we're going to talk about, you guys approached me to sort of, let's talk about neonatal CPAP. Okay, let me ask you first, slightly deviating from what we said we'd do.
Yeah.
Why did you want to talk about this? What was your ideas behind wanting to talk about it?
I think. Hi, Ian. Sorry, by the way. The brief from sort of our point of view is that we're tending to find that we're getting more and more CPAP babies being cared for within the neonatal unit, and the nurses that traditionally look after those have got the qualified in speciality sort of learning beyond registration, teaching or qualification. But because of the volume of these babies that are coming through, we're finding that not all nurses caring for those babies have that qualification.
Okay.
So we're just trying to beef up some education really about CPAP for those nurses. And
that's what we're all about. So CPAP, I do know what CPAP stands for, Continuous Positive Airways Pressure. That's right, isn't it?
Yep.
Good, that's a good start. So, Shaun, if I start with you, so what is CPAP then?
Well, you've termed it right essentially from the off there. So it does stand for Continuous Positive Airway Pressure. Essentially, it's a blend of air or oxygen that's humidified. It's driven through a medical device to provide what we class as CPAP, but it provides PEEP as well, which is positive end expiratory pressure. As opposed to the way we breathe through negative pressure, it's delivering a positive pressure into the baby's lungs. And essentially, we look for what we call a pressure of 5 centimetres of water. But that depends on the baby, and that will obviously be medically sort of prescribed. It's delivered through nasal prongs, and it's classed as non-invasive, unlike ventilation, which is classed as essentially invasive. And its overall aim is to sort of assist with that gaseous exchange within the lungs.
Okay. And I've always kind of described it to my students as, it's the step between baby breathing and air, ventilating. It's something that you're ventilating. It's something in between.
Yes. Yeah, you're absolutely right. Yeah.
Okay. So, Kellie, having sort of said this is what it is, when or why would you choose to use it in neonates?
Yeah, so we actually choose to use it often. It's definitely something that we're leaning towards very often nowadays in neonates. So nasal continuous positive airway pressure, or NCPAP, is a form of non-invasive respiratory assistance, as Shaun said, and it is used widely to maintain patency of the airway. It avoids alveoli collapse and on expiration, and maintains the functional residual capacity, with the overall aim to improve oxygenation. So CPAP also helps to stabilise the chest wall, improves lung compliance and decreases resistance. So it improves greater tidal volumes and reduces the work of breathing for the baby. Respiratory support is given to our sick neonates to maintain satisfactory oxygenation and acid-base balance, and provides adequate ventilation until the underlying respiratory failure improves. When we think of the neonatal lung, it becomes really clear as to why we would use CPAP actually. So our premature babies' lungs are lacking surfactant, and therefore their surface area of the alveoli is inadequate. CPAP helps to provide a continuous flow of respiratory assistance to stop the alveoli collapsing and aid gas exchange. And our babies that are coming through from 23 weeks have got less surfactant in their lungs, because surfactant production only begins in the lungs at 24 to 28 weeks. Okay. And actually, really, our babies up until 35 weeks don't really have enough surfactant to maintain adequate oxygenation. So, interestingly, there's more and more research into non-invasive surfactant delivery, and there's a big trial at the moment, LISA, so less invasive surfactant delivery, and or administration, and that basically just means that we would put an almost stiff NG tube down into the lungs and deliver surfactant that way, so stopping ventilation mechanically. Which has a great impact on these babies. I mean, it's not come into our neonatal network yet, but we are looking to, just use different trials and different methods of administration. There's also a clinical trial at the moment about inhaled surfactant, so watch this space. We may just see CPAP surfactant delivery via CPAP actually.
Okay.
So back to the neonatal lung. The chest wall is very compliant, but their lung tissue is often referred to as stiff. So we hear this often, that babies have stiff lungs. And they're often not strong enough to be able to generate enough tidal volume to maintain their own functional residual capacity. CPAP helps increase spontaneous tidal volume and reduces the respiratory effort. An increased work of breathing is difficult to sustain for our tiny babies, and this together with a rise in CO2 can lead to apnea. Infants with respiratory distress can have asynchronous breathing, so that's that seesaw effect between the chest wall and the abdomen, and for various this can happen for various reasons such as infection or meconium aspiration. And CPAP can help to splint the chest and decrease the effort of breathing until the underlying respiratory failure resolves. And CPAP can be used as long-term respiratory support or a rescue mechanism to help recruit alveoli, and we actually use them in both ways equally on the neonatal unit.
Okay.
Yeah.
So it's kind of looking at saying, okay, these babies need some respiratory support
Yeah.
without wanting the actual support we're giving to damage their lungs, which is often, the worry about ventilating.
Absolutely.
So it's kind of trying to get that balance absolutely right, isn't it?
Yeah, it is.
Okay. So thinking then, we sort of talked about what it is, why you might use it. How do you go about selecting who's sort of suitable for CPAP?
Yeah.
Because these babies don't come out with a label saying,
They don't.
I need ventilating, I need CPAP.
No.
How do you choose?
So we're really often, in the back of our minds, we're thinking we should lean towards CPAP. So almost our first thought is, would this baby cope on CPAP?
Okay.
And so there's many different reasons to choose CPAP over ventilation or high flow or nasal cannula oxygen, as we use in the NICU often. So in the neonate with respiratory distress syndrome or prematurity, it helps the alveoli at the end of the lungs from collapsing due to that lack of surfactant that we spoke about earlier on. The most common use of CPAP is in our mild to moderate RDS, and this just helps prevent the collapse of alveoli with marginal stability. The recruitment of more alveoli increases the functional residual capacity and improves oxygenation. And numerous studies have actually proved that CPAP reduces the need for mechanical ventilation,
Okay.
and probably then the instance of chronic lung disease, which we saw a lot historically in the neonatal unit. At birth, we can decide whether to use CPAP in a spontaneously breathing preterm infant who has some respiratory difficulty. And when we have apnea of prematurity, as we spoke about earlier on actually, decreasing that work of breathing can avoid apnea, so CPAP helps in that area as well. And it is typically used when clinically significant episodes of apnea persist despite caffeine, which we often use. And we do use it to facilitate extubation and support post-extubation also. So CPAP reduces the incidence of apnea, respiratory acidosis and increased oxygen requirement in our very tiny babies. And in tracheomalacia sometimes as well we can use CPAP. So it's just having that consideration whether we're going to use CPAP or whether we're going to need to ventilate these babies. And then signs of increased respiratory acidosis or distress in worsening blood gases, we would choose to use CPAP in that situation as well. And then if a baby is just creeping up with oxygen requirement over 40%, we need to think about using some form of, just increased respiratory support in this situation. So we commence CPAP if the oxygen requirement is over 40%, or if there are other significant signs of respiratory distress. But it is not a substitute for mechanical ventilation. So if we know that these babies are likely to need ventilation for surgery or something like that, or if they are going to need surfactant therapy, so our very preterm babies, we are going to choose to ventilate those babies. So CPAP is indicated in babies with RDS who have a PaO2 persistently below 7, despite an oxygen requirement of over 40%. And we consider ventilation if the PaO2 is not maintained above 7 with the oxygen requirement of more than 40%.
Okay.
So yeah, there's quite a lot of babies that we choose to use CPAP in. It's often chosen.
I'm now remembering why I don't do neonates or tidal volumes. Okay. But I guess, is there, in your experience, is there now a move to sort of thinking, all these babies when they come out, we're going to ventilate them, to actually we're going to CPAP them to start with?
Yeah, we're definitely
is that a real shift in
yeah.
sort of how people think, if you like?
It is. It's definitely becoming more common to have the CPAP ready to go, even in your tiny preterm babies.
Okay.
And we're thinking that is the way to go.
Okay, so sort of less
Yeah.
damage to those lungs.
Yeah.
And I guess that follows on, less damage. What Shaun, what would you sort of say were the other benefits of CPAP?
I think, well, there's some very quick wins to start off with. I think from a parental point of view, it's nicer to look at. Also, knowing from a parental point of view that the baby's actually breathing for themselves. Remember, CPAP, it helps with the neonates breathing. It doesn't breathe for them, unlike ventilation. And this can be a positive sign for baby, and also it can show progress for parents as well. It's easier for nurses to get the babies out to perform skin to skin, which obviously we know enhances the bonding and obviously milk production for the mums that want to express. Parents now, we encourage them to do all the cares, not just nappies. So it could be things like doing NG feeds that we now encourage. Lots of parents feel more comfortable doing that if they're on CPAP as opposed to if they're on a ventilator. Of course, as well, there's no risk of them extubating themselves if they're on CPAP. But we know CPAP has other benefits as well. So they have that reduced incidence of neonates requiring ventilatory support, and that's by about a third of those babies. And by reducing those risks of being on a ventilator, we know that has really positive impacts on babies moving forward and long term as well. I think from a practitioner point of view as well, it gives you options. It gives you an option to think not just if this baby needs CPAP, but you can actually step it up again and you can put them on a method called biphasic CPAP.
Okay.
And that's another tool in sort of the medical team's armoury to either progress baby on it before ventilation as well. So that's another useful one. But like Kellie's mentioned, it does reduce the overall work and effort of breathing. It reduces the risk of apnea, bradycardia and desaturations, and that natural duration of respiratory distress syndrome. But that again depends on those surfactant levels.
So as you said, I think that's a really important point, isn't it, about parents, is that they can see actually, particularly when they're born, a hugely stressful time for these families, to say actually you can see the majority of their face, they're breathing for themselves, as opposed to being, intubated, sedated, and the machine's doing all the work for them.
Yeah, I would agree. Yeah.
I think it makes them seem more real as well. The parents can really get their hands on them, and they can see that they're breathing for themselves. They can see they're not sedated in any way. It's really, really important for these families.
And I think with that issue about cares as well, is I think if I was holding a ventilated child and doing the cares, I'd be terrified that I'm going to do something and it's all going to go wrong. Whereas if the CPAP mask slips off, it's not such a big problem.
No.
So I guess that must be better for parents. You mentioned biphasic CPAP.
Yes.
I looked blank when you said that. So go on then. What's that?
Essentially, it's still CPAP, so we're still delivering that baseline pressure or PEEP of around 5 or 6 centimetres of pressure. But with biphasic CPAP, you're basically setting a rate, and you're giving an extra 2 to 3 centimetres of pressure above that baseline to help the baby breathe.
Okay.
It's important to note that it doesn't breathe for baby. It's just an extra level of pressure. It's essentially to help blow off any extra carbon dioxide that's in the lungs.
So does that, when you're sort of thinking about that rate, do you try and match it to the baby's rate, or?
Yes. So different units do different things.
Okay.
So you can have a trigger biphasic rate where you'll attach a sensor to the baby's stomach, and that will pick up when the baby's breathing, and it will match it to the CPAP.
Okay.
But yeah, as a practitioner, you have a sort of baseline level of where the baby's breathing, and then you'd match your CPAP to that, and then you reduce that accordingly.
So as the baby sort of doing more work for themselves and coping, do you kind of turn that rate down, basically?
Rate down. Yeah.
Okay, so it's not quite ventilation, it's not quite CPAP, it's a bit of extra support.
Yes.
I can live with that. I get that. We're supporting it a bit more.
Yeah.
So we talked about all the positive, amazing, wonderful things that CPAP does, but nothing in medicine surely is without problems. So are there any risks from your perspective nursing a baby on CPAP?
Yeah, so we've convinced you, I think, why don't we use CPAP on every single baby in the neonatal unit? No, of course there are definitely complications and contraindications for using CPAP. And one of our main ones is the CPAP belly. Ever heard of CPAP belly?
Yes,
Yeah.
I suffer from that.
So abdominal distension, we often see that in our tiny, very low birth weight babies, this increase in their abdomen. And that can actually mask signs of NEC or necrotizing enterocolitis, which we are also very concerned about on the neonatal unit. So always watch out for that CPAP belly. We can...
Yeah, because that's sort of something that you go, oh, the belly's full.
Yeah.
Oh, it's just because they're on the CPAP.
Yeah.
Is that why you're sort of worried about missing? Actually, it's not because they're just the CPAP. Okay.
Sometimes we get false pressure readings. So if we occlude the prongs or the soft mask, we can actually look like we're delivering CPAP to the baby. But if it's just on the cheek or on the top of the nose, then we're actually not giving CPAP to the baby. So that's a complication that eventually they're going to get really worn out and start having that apnea of prematurity, bradycardias, and that's quite difficult to see sometimes because obviously in our tiny babies the prongs are very, very small, so it's difficult to see.
So you might think you're actually giving the CPAP, but you're not.
Yeah, so our machine is telling us we're giving very high pressures of CPAP, even we could turn it down, but actually we're not giving anything to the baby because it's on their cheek or on the top of their mouth. Yeah.
So then whoever's looking after them has to be quite vigilant that actually I'm happy that mask is in the right place.
Definitely in the right place. And of course babies move all the time, so it's quite difficult to tell. We can sometimes get an air leak, so actually, again, we think we're delivering pressure, but we're not. If the baby's got its mouth wide open, the pressure is just coming straight out of the mouth and not into the lungs. And we start to see that the baby gets very, very worn out again and is looking like it may need a step up to biphasic or even ventilation. And so that's definitely something we have to look out for when we're nursing a baby on CPAP. Excessive flow can prevent exhalation, which will increase the PEEP and result in overdistension, and this puts them at risk of pneumothorax, so we shouldn't be giving excessive flow. And again, sometimes if they've got their mouth wide open or it looks like we're really giving minimal pressures, we think about turning the PEEP up, but actually that's not the right thing to do. And then one of the main things that is a contraindication for using CPAP is the nasal breakdown and skin breakdown, because you can imagine that CPAP has to be on quite tight, and like we said, babies move. And so we have to ensure that the fixation device is on correctly and securely, but at the same time we are risking a skin breakdown on our skin that's very fragile anyway. So being really vigilant with your skin care and nasal care is really important when you're nursing on CPAP. The septal distortion and pressure necrosis of the head and the neck, and it's really something that does happen to babies on CPAP, so we have to watch out. And then irritability. You can imagine our big term babies that we put on CPAP, they really don't like to be on CPAP and they will almost fight the CPAP. So it can lead to restlessness and an increase or labile oxygen requirements, so just have to watch out.
Have either of you ever put a CPAP mask on?
Yeah, I have actually.
I haven't actually.
It's really unpleasant.
Yeah, it's really, really unpleasant. And it even made me think, I've forgotten how to breathe.
So when you're sort of seeing these babies, you say fighting them, actually, it's worth remembering it's actually it's not a pleasant experience to have this sort of forced into you. And it's interesting with you sort of saying about that skin damage, that's a real problem, isn't it? And it's as well as sort of the tapes over the cheekbones, but real problems with breakdown of the nasal septum. And other than being vigilant, is there anything else that the nursing team can do to
I think
help with it?
Making sure we're using on the fixation devices that we use at Northampton, making sure we're alternating between the mask and the prongs and changing very regularly. And then also making sure that we're checking underneath the bonnet and making sure the ears are okay. So as part of the cares, we really do need to be looking underneath the bonnet, underneath the tapes, releasing a little bit and giving that, pressure relief for those babies.
Because I guess those bits, if they're hidden, could easily be missed.
Yeah,
potentially.
Absolutely.
Okay. So those are some of the risks. If we move back then to you, Shaun, to sort of say, okay, my baby's been settled and comfortable on CPAP. What are the things that somebody might look for to say, actually, I wonder if my baby's now not coping with CPAP?
I think that probably the first thing you're going to see is a rise in oxygen requirement for that baby. That's irrespective of whether on biphasic CPAP or normal CPAP. And any baby that you're worried about, I would always encourage to get a blood gas done as soon as possible, whether that's you as the nurse that needs to do it or you need to escalate it to the medical team. And I think with that you often see what we call a respiratory acidosis, so a lower pH and a rise in CO2.
Yeah.
You might notice that your baby's having episodes, and when I say episodes, it could be the fact that they're having apneas, bradycardias or desaturations. You might notice as well with your trends and your vital signs that you have a baby that's decreasing their oxygen saturations. So you've got a baby that's plodding along quite nicely, and then you'll just notice that your saturations just start dropping even. So that's why it's really important to keep an eye on your vital trends. So not just when you're coming onto a shift in the morning and you're coming onto an early, you're only going to have sort of 7 or 8 hours worth of vital signs. I think it's important that you make that assessment to look back over the past couple of days worth of charts even to see what is your oxygen requirement, what have your pressures been like, what's this baby's gas has been like. Because if you are worried and you're doing a gas, it's important to compare it to see how they're progressing or not, as the case may be. So things like that, if you are worried, obviously it does require immediate escalation to the medical team. This baby, it could potentially need an chest x-ray. I think you need to listen in as well to your chest to make sure that you've got bilateral chest movement and that you've not got potential pneumothorax there. But it comes back to your basic nursing assessment. Look at your baby. What's the colour like? Is the tone the same? Are they themselves? And I know that's quite hard for sort of newborn babies to assess. But for your long-term babies that are on CPAP for 40, 50 days, it should be quite obvious if they're not themselves, if they're a bit quieter. We often use parents as a cue, don't we? So it's sort of those things that you need to be vigilant on.
And I think that goes back to sort of your point, Kellie, about the looking at your baby, not just the machine, because the machine might be saying everything's fine and your baby's saying things are not fine, and actually look at your patient, use the machine but look at your patient. And are there any other sort of particular things that you, when you're sort of educating your nursing colleagues who may be new to CPAP, are there any other sort of things that you emphasise to them?
Yeah, so Kellie's already touched on them actually. It's the basics, getting the basics right. So we spoke about fixation. If that fixation is not in the right place, you're not going to be delivering CPAP. Yep. So they're not delivering what's prescribed basically, so it's pretty much useless. Making sure that your pressures are set to what is prescribed. If your fixation's not right, you're going to lose pressure.
Yep.
It's that simple basically. Positioning your neonate as well, obviously they should be comfortable, or try and support them as best you can, but you need to be visually aware, so you need to be able to spot them and look at them. Measuring for the hat, so this is a bit of an issue for me.
Okay.
People think that the head circumference is the same as a hat measurement. It's not.
Okay.
A hat will sit around the sort of bottom of the neck. It doesn't sit on top like a flat cap.
Yeah.
So it is there are different measurements. So make sure you've got the right hat size, because if you've got a hat that's too big, you're not going to be able to get the fixation right. You're going to end up pulling your ties to make sure that it's delivering the pressures basically. Making sure that your tubing on the CPAP circuit sits nice as well. I see it quite a lot where the tubing is outside of the incubator and it's pulled quite tight. So encourage that tubing in so it's not pulling on the babies. You've said about ears, they should be inspected at least daily, definitely. And calibrating your machine. Certainly when you turn the device off, you should be calibrating the oxygen every time basically to make sure that you're delivering what is prescribed essentially.
Okay. Good advice for us all there. Check your ears daily.
Yes.
Okay, so Kellie, if we then finally move on. So my baby's done really well. They've coped on the CPAP. They're now getting bigger. They're able to breathe more for themselves. Yeah. How do you sort of wean them off, and how do you get them into nasal cannula oxygen or whatever?
I think if you knew the answer to that, you would probably be a very, very rich man, because actually we don't know.
Okay.
We don't know exactly how is the best way to wean off of a CPAP device. And actually it's really interesting how different units do different things. I've worked in many different neonatal units and we all did different things, but the babies essentially got to where they needed to be at similar times. So it could be just making sure that the treatment is individualised, so making sure we're looking at the baby, because some babies go from needing very high pressures of CPAP and high oxygen requirements to actually needing nothing at all. So being able to have that confidence to say this baby could come off CPAP completely is the right thing to do in some cases. But then, as Shaun said earlier on, that some babies are on CPAP for 40, 50 days, and weaning very, very slowly is the right thing to do for them. So it's just making sure that we have that understanding of where our baby is, where it's come from, and where we want to see it in the future. Because some babies we know will go home with an oxygen requirement and go home with nasal cannula oxygen, and our big term babies, we are hopeful that they, in a couple of days, will no longer need CPAP.
Okay.
So actually, yeah, we don't really know.
Right.
But,
well, that's reassuring.
Yeah, and it's the same actually with lots of things in neonates. It is making sure we're doing that individualised care. But blood gases can assist us in finding out whether the weaning that we are doing is correct for that baby, and yeah, it's very interesting how diverse the culture is. Sometimes they can use high flow as a step down.
Yeah.
Some units don't use high flow at all, some units use cycling on and off CPAP, which we don't actually do in Northampton. So it's very difficult to know exactly how is the right thing to do.
Because I was going to say, when you're sort of thinking about weaning, do you wean in terms of pressure? Do you wean in terms of time, or does it?
Yeah, again, it does vary. Yeah, it does definitely vary. In Northampton, we're very keen on weaning the pressure slowly as the oxygen requirement goes down, and then being brave enough to take off the CPAP completely. And Shaun is looking at me like, they don't do that.
We don't do that here. No, so we tend to stick them on the pressure of 5 centimetres, and they're not below. Come down below that.
Okay.
So, but then, do you start them on higher pressures?
We do, yeah.
Yeah. So we don't start them on higher pressures.
Okay.
So, but we advocate having time off. So we might start them off an hour off with cares, 2 hours off twice a day, and then increase it until they're eventually off.
Okay. So there's no. As yet, this is exactly how you should do it. And as I say, I think that's really important, isn't it? You personalise the care to that baby, and those experienced nurses who've looked after this baby will probably know coping, not coping.
Yeah, absolutely.
Okay.
Yeah.
All right. Is there stuff looking at how's the best way to wean?
Yeah, so actually there's lots and lots of research going into the use of high flow. So that seems to be the way that people are going as a step down, using high flow. But again, it's not something that's used in the whole of our network, so it's surely not being used in the whole of the UK. So yeah, watch this space really. Neonates changes all the time, you know.
Okay. So that's CPAP. If you were going to say, summarise a take-home message then that you wanted for somebody who's coming in as a fairly new neonatal nurse to look after a baby with CPAP, what would your take-home summary and messages be?
I think what I would say is that you have to remember that these are classed as high dependency babies.
Yeah.
So with that in mind, these babies still require hourly obs, and they still need that visual assessment and assessment every hour essentially. If you're worried, do a gas.
Yeah.
I always like that, and essentially just escalate any concerns that you've got.
Yeah.
Okay.
I would say that really use the parents as well in these situations. So they are the experts in their baby's care. So do ask them for their advice. Not for their advice, maybe for their input. How does your baby look today? Is this normal for your baby?
Okay.
Don't be afraid of CPAP. Actually, is one thing I would say. If you're going down to the delivery room of a preterm baby, think: could this baby go on to CPAP? Is that the most appropriate thing? And then again, I'm really looking forward to the less invasive CPAP therapy that's going to come through very soon, I hope.
Okay, fantastic. Well, thank you very much for your time. I've learned lots, and hopefully that those people listening to us will learn lots as well. So thank you very much, Shaun. Thank you very much, Kellie.
Thank you.